Hello, everybody. Welcome to our presentation today. Just going to give some people a few minutes to log on. For those of you just joining, we're going to begin in just a minute or so. Just waiting for everybody to get logged on. And again, just a reminder, just going to begin in one more minute, just giving people an opportunity to get signed in. All right, everybody, we're going to go ahead and get started. So welcome. I am Jess Eyre. I'm the Regional Resource Director for Maryland with Caron Treatment Centers. Thank you for joining us today for the webinar, Therapeutic Confrontation in Substance Abuse Treatment, Setting Boundaries and Challenging Concerning Behavior. Today's presentation is hosted by Caron Treatment Centers, Maryland Addiction Recovery Center, and Encore Outpatient Services. As a reminder, we will be conducting this session in webinar format, meaning all participant microphones will be muted. We will not be able to see or hear you. During the presentation, please utilize the Q&A feature to ask any questions. Depending on the volume of questions, if we can't get to your question before the end of the hour, someone from our team will follow up with you directly. Today's presentation is eligible for 1 continuing education credit. We would like to thank our educational partner, CE Learning Systems, for assisting in providing these credits through co-sponsorship with the APA. Please note that in order to receive your credits, you will need to complete the post-webinar evaluation. A link will be emailed to you directly after the presentation from cego.com. After finishing the evaluation, you will have immediate access to your certificate of completion. Today, I am proud to introduce our presenter, Caroline Iciek. Caroline is a senior clinician at Second Chance Care, an addiction and education center in Potomac, Maryland. She previously worked as a program director, primary therapist, group facilitator, and clinical intern at recovery centers for alcohol and substance use. Caroline's passion and commitment to supporting those struggling with substance use concerns has manifested into lifelong mission of continued education and clinical improvement. She utilizes cognitive behavioral therapy, motivational interviewing, and goal-oriented techniques to promote each individual person's strengths and empower them to be successful through the course of treatment. Please welcome Caroline.
Thank you, Jess. My name is Caroline Iciek, as you've already heard, and I am the senior clinician at Second Chance Care. I have worked in a variety of settings in the substance use treatment field, from residential to outpatient programs for adults 18 years and older. My role at Second Chance involves providing oversight to the clinical program and mentorship to the staff. Our treatment facility is a boutique-style intensive outpatient program that offers individualized treatment to clients 18 years and older to better help them achieve their recovery goals. We offer flexibility to clients when creating their schedules by offering both in-person and virtual sessions with the option of morning and evening hours. We recognize that treatment's goal is to help the individual reintegrate into a daily routine where they can show up for their family, friends, work, and outside support groups. Therefore, we promote the flexibility so that there is not a barrier for them to commit to treatment and they get the help they deserve. We also offer an outpatient track for Spanish-speaking clients and a DUI education program. So the key objectives of this presentation are to explain key concepts of substance use disorders, describe common family roles in family systems where someone suffers from a substance use disorder, explain why confrontation may be necessary in providing treatment, and identify when confrontation may be necessary as part of treatment, and describe effective use of confrontation in a therapeutic setting. To understand why it's important to incorporate therapeutic confrontation into treating substance use disorders, we must understand what is going on in the brain of someone who struggles with addiction. So let me put it into perspective. Think about that time you got your first bike. Your parents tell you you're getting the bike, you're on your way to pick it up, and you could practically burst from excitement. Then you see the bike, and it is better than you could have ever imagined. You feel like the coolest kid on the block, that you finally belong and fit in. And the next day, it's still exciting, but it does not necessarily bring the same level of joy it did that day you first saw the bike. And then slowly it becomes less exciting as each day passes. You might enjoy it, but it's not as thrilling as it once was. Eventually, it goes from the means of fitting in to just a means of transportation to get from point A to point B. This is what happens in someone's brain when they start taking drugs. The first time someone takes a drug, it's a new foreign substance, like that shiny new bike. So the reward center of the brain is activated, and dopamine, that feeling of pleasure, is rapidly fired in comparison to it at its baseline. This is what people are experiencing when they describe the euphoria of their first high, the one they are always trying to achieve thereafter. The moment this happens, the memory and conditioning start to take place in the brain. Your brain begins making associations with emotions, stressors, events, people, with the response of taking a substance. When a stressor presents itself, it will trigger the memory of using drugs and alcohol in your brain. So it starts with an uncomfortable feeling, such as increased anxiety when you're about to see a family member you're having a disagreement with. The anticipation almost feels unbearable, and all you want in that moment is relief. This will send a signal in your brain reminding you of the time you felt instant relief when you took drugs or drank alcohol. Each time you respond to an uncomfortable feeling or situation with the response of drinking and using drugs, you reinforce the notion in your brain that you need the substance to experience relief from the discomfort. During this process, the brain becomes used to the substance, and it no longer fires dopamine as rapidly as it once did when you first started taking drugs. Think back to the bike example. This is like when you had the bike for a while and your enjoyment surrounding the bike started to decrease. Eventually, the baseline of neurotransmitters such as serotonin and dopamine, the feelings of happiness and pleasure, are lowered because of the tolerance your brain starts to build. This is when you hear people start to suggest that their drug and alcohol use went from a feeling of pleasure to just a means of feeling normal. Remember the analogy with the bike, where it went from a sense of connection to a means of transportation. Eventually, someone is just trying to use enough to get to that previous baseline of dopamine and serotonin and feel normal. The parts of your brain associated with executive functioning, such as decision-making and emotional regulation, are not operating at the capacity they once were before drugs were introduced. This is an important point to take into consideration as to why someone won't just stop. We can utilize the part of our brain that allows us to rationalize when it has not been physically altered by drugs and alcohol. However, this part of the brain is not functioning at the same effectiveness when someone is high, drunk, or craving drugs and alcohol. Moreover, compulsive activation of the reward center of the brain elicits increased stress signals. It is like when you feel exhausted after an exciting event, like planning a wedding. While the overall event is exciting, it brings stress and exhaustion along with it. Stress can activate the fight or flight response in someone's brain, overriding the executive functioning part of the brain, because the signal is saying we are in danger and we have no time to waste to get us to safety. Fight or flight is an adaptive response when you're in life-threatening danger, like being chased by a bear, but not so much on a daily basis. Being in a constant state of panic is not conducive to anyone's daily life. The fight or flight response suggests that using is needed to survive. That explains why you may hear desperation in someone's voice when they are trying to get drugs or alcohol. You may notice them become physically anxious, observing them having racing thoughts, sweating, shaking, or they may become aggressive and angry. Because anyone who prevents them from obtaining the substance is preventing them from getting what they need to survive. The more the substances are used in those moments, the further the thought process is validated and reinforced. While it is important for us to address the neurological reinforcement and adaptation that it occurs in someone's brain when taking drugs, it would be neglectful to not address the reinforcement that occurs in relationship dynamics. It is not uncommon to see codependency amongst family members of someone with a substance use disorder. When I say family members, this does not just mean biological family. This can be close friends, significant others, really anyone who has a close relationship with a person suffering from addiction. It can be easy to rationalize the codependency, but at the core of it, the behavior enables overcommitment and lack of boundaries within the family system. There is an innate desire as humans to maintain a sense of homeostasis, even if it has adverse effects, because it's what we are used to. To this end, a family member may be hesitant to challenge a loved one struggling with addiction in an effort to keep the peace within the family system. There could be spouse, siblings, so conflicts avoided to prevent disrupting that status quo. It is much different. It is essentially becomes a survival mechanism, not much different from the substances are to the person who is abusing them. Also, the enabling behavior can appear as a protective measure, as there are few things more terrifying than being in the unknown of someone who is struggling with addiction. So in a codependent frame of mind, it is justifiable to enable the behavior because at least they know where the person is. And if they can keep their eyes on them, nothing bad can happen to them, right? It feels right, and tough love feels counterintuitive, but it's really the best thing an individual can do so the individual can make changes to pursue long-term recovery. The reason being is that each time the manipulation is enabled, the pathway in the brain that says, see, you did need it, or you needed to do that to survive, is validated. The lack of boundaries is reinforcing the thought process that the individual cannot survive an uncomfortable feeling, and the only solution in that moment is to use drugs and alcohol. For example, I previously worked with families where children moved back home where they were not respecting the boundaries in the household. Each week, we would have the same conversation with the parents, what to do to see the desired changes in the client. I would suggest to the parents about having a family session and set boundaries and expectations in a collaborative manner with their child. I would suggest to the parents about the importance of reinforcing the boundaries because a boundary is only as effective as their reinforcement. If a child knows they can throw a fit and get their way, it's not going to promote any long-lasting change in them. Commonly, I would see parents hesitant to reinforce boundaries because they were worried about their child becoming reactive. They provided past examples where the child started screaming, shouting, they stormed out of the house. They blamed their family member for their substance abuse. So while the parents would say there needed to be change, the execution to making those changes were uncomfortable for them. But without the reinforcements, they consistently enabled the behavior that they desired to see change in. I would challenge them that if their child never receives the consequences, why would they stop using drugs or respect their parents' rules? Our jobs as professionals is not only to help the person seeking treatment, but their family members as well, so they can set healthy boundaries for themselves and heal. It is important to recognize that setting boundaries is easier said than done. Because when someone is experiencing cravings and in that fight or flight mode, They are in survival mode. So setting boundaries with them is preventing them from obtaining what is needed in their mind to survive. This is when you may witness someone becoming physically anxious, start cursing, yelling. They may threaten to leave and never speak to you again. It is more critical than ever in this moment to remain firm in the boundary because consistency is key. The reaction from the individual can be exhausting, and a family member may want to give in just to keep the peace and stop the yelling. However, this will strengthen the pathway because the individual is still learning they need the desired outcome of using drugs, and if they throw a fit, they'll get what they want. Substance abuse is commonly considered a coping technique, a physical way to avoid uncomfortable situations and emotions. The behavioral reinforcements previously discussed support the idea if it makes you uncomfortable, you don't have to deal with it. Simply, when an uncomfortable feeling is felt and someone uses drugs or alcohol to cope with it, the discomfort is lifted temporarily. It feels like a solution because it's practically instantaneous. The key word, though, is it is temporarily lifted. This solution is actually only perpetuating a cycle where we are constantly faced with the fear we were trying to avoid in the first place. Because when the high or the drunk fades, the issue is still present. The stressor will persist because it is not being addressed. Since a person is conditioning themselves to only utilize coping skills that provide instant gratification, it's a hard concept to accept that difficult emotions will not be instantly removed. It can take time, therapy, ups and downs to truly address the situation. And this does not sound particularly ideal when drugs and alcohol instantly take the pain away. However, it is acknowledging that the avoidance went from being a solution to enabling the problem to continue. After many years of avoidant behavior, it is not realistic or safe in some cases for someone to experience depressive symptoms, anxiety symptoms, trauma on their own. As I mentioned earlier, substance use was a survival method in many ways. So people deserve a safe place to process these emotions and learn new ways to address them. And this is where treatment comes into play. In the helping profession, and just as humans in general, we have an innate desire to be liked, no matter how tough we try to act. It is validating to receive the feedback from clients about being the cool therapist, the chill therapist, the funny one. So it's not necessarily comfortable to be the one holding boundaries. The important thing, though, to keep in mind is, why does someone come to treatment in the first place? What is the goal of treatment? Our jobs is to help clients make changes and prepare for life as a sober individual. Life is not only about positive times, happiness, and receiving validation. You go through all sorts of life experiences that help you appreciate the good times, that help you identify what happiness is, because how can you know what a feeling is if you have nothing to compare it to? Treatment should be a small example of what real life will look like for the person after they return home. So this does not mean addressing conflict with your family, with other clients in treatment, avoiding it and ignoring the underlying depressive symptoms or anxiety symptoms or history of trauma. You learn your strengths, your values, your likes, your dislikes, and boundaries through experiencing the good, the bad, and the just okay. So many times clients will come to me and say, that group was horrible, I didn't like it. And my response to them is great, because you're getting sober and you're learning about yourself as a sober individual. And that means figuring out what you like and you don't like. So you didn't like group. That means you don't like it. Great. You're one step closer to figuring out who you are. It feels uncomfortable. If it feels uncomfortable, it probably means change is occurring, because your brain is working hard to relearn new behaviors and create new pathways. So we, as the helping professionals, should acknowledge that these feelings are there and the experiences are real, but there are much more adaptive coping skills to address the discomfort and live a fulfilled life without the use of drugs and alcohol, and avoiding addressing the stressors. is not going to help us toward that goal of recovery. This means pointing out discrepancies in what clients are saying and what their behaviors are suggesting, questioning if their tones align with the tone of an adult that they so desire to be treated as, challenging them to address their feelings with friends, family, significant others, rather than avoiding the situation and developing a resentment and wondering why nothing changes. Sometimes it even means questioning when they continually share what seems like an unrealistically perfect recovery journey, seemingly telling you everything they think you want to hear. The method of confronting clients feels paradoxical, but it actually demonstrates the compassion and empathy we are trained to offer as helping professionals. We are saying we care about the individual and want to see them live a fulfilled life. We care so much that we are unwilling to enable behaviors that ultimately brought them into treatment in the first place. We are here to create a safe environment so that the first time they inevitably experience these feelings is not after they complete treatment, when they do not have a therapeutic space to fall back on and process the emotions. To help put this into context, I thought it would be helpful to provide a case example. My first supervisor, Karen Moore, really taught me the importance of confrontation in treating individuals with substance use disorders and how it truly promotes the changed behavior for the person after they leave treatment. I previously worked in a residential program where my caseload was primarily young female adults, which led to tension amongst them at times. And there were 2 female clients in particular who had formed a strong friendship while in treatment. However, as treatment progressed, tension began to arise in their friendship, which was not being addressed by either of them. And for perspective, one client had learned to reactively respond to conflict because that's how she felt heard. Another client had learned to withdraw from conflict, which only perpetuated boundaries being crossed in her relationships. Each of the clients were coming to me in their individual sessions, venting about the strain in their relationship, how it was making it uncomfortable for them to open up in groups and back at the housing, and because they were not addressing the elephant in the room. So I challenged the clients to address it in a group setting. Clients were asked to identify a conflict during the session in chairs facing one another. Old clients would warn new clients that to be aware that anytime you see Caroline pulling 2 chairs into the group room, because that meant things were about to get real. I allowed the clients to volunteer to participate in the activity, and they were allowed to ask someone they were having a conflict with to participate with them. While they were allowed to volunteer, they knew I was aware of the current conflicts and that I could out-silence them all. So eventually, people participated. The important aspect of this activity was to set ground rules, because the goal is to teach more adaptive methods of direct communication and how to have a healthy conflict. So clients were tasked to utilize different skills, such as I statements. So I felt this when this happened, and stray away from you, because when someone starts saying you did this, you did that, you're this, you're that, even if the person's completely accurate, the other individual's wall will immediately go up, making the conversation effectively ineffective. They were also tasked to not curse. While I do believe there are many therapeutic benefits to cursing in therapy sessions, for this particular session, it would not have been helpful in teaching someone how to have a healthy conflict. They were asked not to raise their voices, so they did not activate that fight or flight response and could continue to engage in a conversation and hear each other. And most importantly, no peanut gallery contributions from other group members. The goal of the activity was for the 2 individuals involved in the conflict to address the present conflict at hand, not what has happened in the past, not what could happen in the future, what is happening right now. The tension and anxiety were palpable, not only with the clients, but myself as well. I could feel the reactive client starting to get irritated. She was fidgeting and sounding exasperated. The other client was struggling to make eye contact. You could hear her shakiness in her voice. She was picking at her to-go coffee cup. And at one point, the reactive client had to step out and smoke a cigarette. And that was perfectly okay. She utilized a coping skill to prevent herself from getting into a fight or flight mode so she could continue effectively communicating with her friend. She implemented a physical pause, which is different from avoiding the situation altogether. When she returned to the group room, she was able to sit down with her friend, and what happened was beautiful. They were able to communicate their feelings and perspectives of the situation without becoming accusatory towards one another. Direct communication is sometimes inaccurately labeled as a negative situation, but truly it demonstrates how much you care about another person and your relationship with them, that you're willing to be honest because you want to see it repaired. I remember questioning, and as the tension was rising, if this was the right activity. Did I push them too far outside their comfort zone? Were they ready for this activity? But our jobs as counselors is to model the behavior we are trying to teach clients to adapt in their own lives. So if I'm encouraging them to get outside of their comfort zone, I may have to as well. And this was a perfect example of that. This activity ended up being one of the most beneficial interventions of their treatment process. And this is not necessarily me patting myself on the back. Rather, it was from the client's feedback about the activity. They were able to process their emotions and how intense those emotions felt, but they were able to resolve the conflict in their friendship. They were able to not do so and use over it. They had a safe environment to feel those feelings. They had not had an experience like this in many, many years. And now they were able to go back into treatment, engage in the group process, having addressed the elephant in the room, and truly receive all the benefits from active participation in the treatment process. Conflict is a solution that will inevitably be presented, an individual will inevitably be presented outside of treatment. When those situations arise, this activity aided clients to build their confidence that they can successfully handle the situation without drinking or using drugs, or just avoiding it altogether. They now had a reality-based example from their own experience that they could use to challenge any potentially distorted thought processes, such as catastrophizing, telling themselves they could not survive the discomfort that comes from conflict because they knew from their own experience they could. So now, when do we use confrontation? Now that you have all this information, I am not suggesting that you go confront your client about projecting their anger towards their mother onto you during their first individual session. Clients need to trust you. Research shows that feedback gained from confrontation is better received when the counselor is perceived as caring and trustworthy. Simply, you need to establish and foster a therapeutic rapport before this can be effectively implemented into therapy. Remember, confrontation is an invitation to gain a new perspective. While it is important to hold boundaries and challenge clients, it is not our job to force upon them a new perspective. It is their choice to accept the new point of view. As a helping professional, we should present it as an option rather than an absolute. We cannot force them to accept any feedback, but it does not mean we stray away from giving them the feedback. It is also important to assess the client's readiness to receive the intervention. So how do you know when it is time? Look at how the client is opening up to you during the sessions. Are they sharing details about relationship dynamics? Are they talking to you about their fears? Do they start opening up to you about their childhood, trauma experiences? Simply, are they getting vulnerable with you during their sessions? These shares demonstrate a level of trust they are forming with you, suggesting they may be ready for confrontation to challenge thought processes. However, when it is appropriate to utilize confrontation, it is critical that you do not attempt to confront too many maladaptive behaviors at once. We only have about 45 minutes in a session, so we cannot expect them to change all maladaptive thinking at once. Previously, I provided a case example where challenging was effective, and I thought it would be helpful to offer an example where I did not execute it perfectly. There was a client who struggled with those obsessive compulsions where he would compulsively check his appearance. These compulsive behaviors disrupted his daily routine, preventing him from fully engaging in treatment. He was either late to his therapy sessions or he was distracted by the obsessive thoughts. I would catch him looking for his reflection to check his appearance in session, and he couldn't really focus on what we were talking about. I attempted to get creative and address many of these compulsive behaviors, but I ended up challenging way too many at once. I assigned him 3 different behavioral techniques to delay gratification of acting on the obsessive thoughts in 1 week. I needed to remember that the compulsions are learned after many years and repeated reinforcement. So asking someone to make changes in 3 areas of their life in 1 week is not realistic. The key is breaking it down into reasonable goals. Many times we will see clients come to treatment with lofty goals from themselves that they have already established before they get to treatment. And while it's important for us to acknowledge and empower them to set these goals and have hopes for themselves, we also want to teach them how to set reasonable and achievable goals to get to that long-term goal, how to appreciate the small wins along the way. This prevents clients from self-fulfilling prophecy where they think they are a failure and they set these big goals without a plan, and then inevitably they cannot execute it and subsequently engage in self-loathing behaviors, which can lead to relapse if they're not addressed. Thankfully, I had engaged the clinical team by informing them of the clinical intervention. This allowed the team to provide me with observations on how the client was processing the interventions and their feedback on the intervention overall. They suggested that it was too many changes for the client to address at once. They were seeing him become anxious and uncomfortable during groups. I was able to take a step back, reassess the situation. I worked with the client to simplify the intervention into more achievable goals, modeling the behavior that we desire to see the client practice. As we have discussed, behaviors are not learned overnight. It takes continual reinforcement to learn and strengthen new behaviors. The key is consistency. When you are implementing a new clinical intervention, it is essential that the clinical team is working just as a team. Let the members of the team know so that they can reinforce the targeted behavioral change in all therapy sessions. So creative interventions should be sent to the clinical team by email or discussed in team meetings to support the client in consistently practicing the new behavior. I would inform the client that I was going to notify the team as a means of maintaining that rapport and trust that we had already established. Also, notifying the team prevented any staff splitting, reminding the individual they cannot manipulate the situation to get their desired outcome. Again, we are teaching them a new adaptive behaviors to be successful as a sober individual. So throwing a fit or trying to manipulate a situation by going to every staff member until they hear the answer they want to hear is not a sustainable life skill, because that is just not how life works. As I mentioned earlier, many of these behaviors have been learned in the individual's environment outside of treatment. So while the reinforcement in treatment can be helpful in their future, the work will be lost if they do not continue practice it when they return home. Engage the family in the treatment process. Sometimes it may be beneficial to first meet with the family member without the client present, obviously if the client consents to it. This will allow you to gain another perspective of presenting a problem. Ask the client and family members to set goals for the relationship. Coach the family members and clients on communication and boundary setting. This takes time, as these behaviors are not going to necessarily feel comfortable right away. This is where the rapport building comes into place. When you feel resistance from the family member or the client, reflect on what they've previously shared about the relationship dynamics. Challenge them to consider if not approaching the relationship differently, will help them achieve the goals they identified for their relationship. It is like the old saying, if nothing changes, nothing changes. You can teach and practice direct communication skills with the client to utilize in their family sessions. Think about back to the case example where the ground rules were set. I statements, no cursing, try not to raise your voice, make eye contact whenever possible. As we teach the clients and family members to reinforce the boundaries, we need to do so as well as the professionals. Let the families know that if screaming and cursing start, the conversation will be paused and resumed at a later time. Implement the physical pause we discussed earlier so they can return back to a later time and have an effective conversation. So many times I would work either with younger adults, even sometimes older adults, and they'd be trying to communicate their feelings to family members. They wanted to be treated as an independent individual, someone who has their rights and values and as an adult. But they were so frustrated and tired from all the pain and exhaustion addiction brought that they tended to get reactive and they would scream, they would curse. And as we talked about earlier, the family members shut down. They would say, see, this is what I'm talking about. I can't take them seriously. And it was really important for me to talk to the clients about if you want to be heard, you need to be calm. So when we practice it in sessions, I would ask them, does that sound like what an adult would say? Especially when when I was working with young adults, to help them gain this new perspective and that they could be heard because their rights, their boundaries are just as important. They just needed to learn how to effectively communicate that to family and accept that they may not be heard or agreed with. And having these interventions within the sessions and during treatment allows you as the helping professional to have direct observation of how they are implementing the tools that they have been taught. This will make the feedback more accurate and provide the opportunity to identify what's needed to continue to be addressed in treatment so that before they complete treatment, they have a lot of the tools to sustain the learned behaviors afterwards. Encourage the client to share what they have learned and are working on with the family, and how the family can help them continue on this path after they leave treatment. Asking the client to verbalize their goals to help them in the future. Because when it is being reinforced, it is not about what someone is telling them to do, rather it's what they said they needed to do. Think of the family as an aftercare plan. Their role will be vital to sustaining these behaviors after they leave treatment. The goal of substance use treatment is to teach individuals adaptive thought processes and behaviors that allow them to experience their lives without the use of drugs and alcohol. This requires utilizing confrontation and setting boundaries to promote this change. The first time a client experiences a stressor or an uncomfortable emotion should not be after they leave treatment. It is important that an individual has an opportunity to have this experience for the first time in a safe and therapeutic setting. So when life inevitably shows up, the individual has the confidence that they can handle this life event without the use of drugs and alcohol. Avoiding, challenging, and confronting individuals about maladaptive behavior because it makes us uncomfortable is a disservice to that person. And all we are doing is reinforcing those old behaviors. So what would the point of treatment be? And while challenging someone does not necessarily feel caring and compassionate, it's actually exactly that. As we discussed earlier, we are showing how much we care about the individual to live a fulfilled life, that we are not willing to enable the old behaviors that brought them to the treatment process. So when they push back, when they get angry, talk to them about them. Clients want to be treated as the humans they are. We don't need to trick them. Be transparent, be honest with them with what's going on. Acknowledge their feelings. Yes, this may feel tough, but this is the purpose of it. Help them understand the goals. Just as recovery is not a solo journey, the treatment process should not be either. Engage the family members and treatment team in the process to further help the individual reach their treatment goals and learn new behaviors. Treatment is 28 days, maybe it's a couple months, but that's only a fraction of the time in the person's life. So you need those outside reinforcements to really promote long-lasting change. As helping professionals, we are not here to perpetuate the cycle of avoidant behaviors and keep their secrets. We are here to promote vulnerability and teach direct communication and work in a collaborative manner, whether that is with the family, peers, or the treatment team. And telling the clients, be honest with them. I'm not here to keep your secrets. I'm going to talk to the team so you get the services that you deserve. And explain to them why this is going to benefit them in the long run. But make it collaborative so they understand and they feel part of the treatment plan that's helping their life. So with that, I would like to thank Karen, Encore, and Mark for asking me to present. And it's truly an honor. And I want to thank Second Chance for helping me grow, all my mentors, Larry, Victoria, Karen, Rachel, for really helping me grow as an individual. Thank you. And now Jess will moderate questions.
Thank you so much, Caroline. That was a wonderful presentation. We're going to go ahead and ask you some of the questions that were submitted earlier during the registration process. And then if there's still time, we'll jump into the live questions that came through. So first question, how do you ensure that a client understands why purposeful boundaries are set and that they're not punitive or personal?
I think in those situations, it's important to acknowledge that it sounds like it, right? Like, I get why you feel like this feels punitive, and just being honest and direct with them and not pulling the therapist tone, saying like, it makes sense that you feel this way, acknowledge their feelings, but go over their goals. Because when they come to treatment, they set these goals for themselves. And it's engaging them using that motivational interviewing process to be like, okay, this is what you said you needed. I'm holding this boundary with you to get you to the goal that you set for yourself. So it's really reflecting back on previous things, because when they're upset or angry, they're not thinking back to, oh yeah, 15 days ago I said I wanted to do this, because they're in the moment. So
Right.
It's helping them process that and staying calm yourself.
Perfect. Great. Caroline, what are some de-escalation strategies when confrontation triggers an intense emotional response?
So the key is, as we talked about earlier, we are modeling behaviors we want to see in them. So it means you're remaining calm yourself. So if they are cursing or screaming at you, you don't engage. And this next response will probably make them angrier. You say, when you're ready to talk calmly, you know where to find me. I mean, I can't tell you how many times I've been followed down the hall with a client cursing at me, but I was not going to engage because it was going to waste both our times. We were going to talk in circles. So it's keeping your voice level and calm. Don't raise it. Don't curse. Stay calm. And when they take a moment to take a breather, like that physical pause we talked about in the case example, they can come back and have a calm conversation. Even if they're not happy, they're usually they're cooled off.
Yeah. And, kind of modeling the behavior you want to see rather than matching the client's intensity.
Right. That's not helpful to anyone.
Right. So how do you determine when a client is not following appropriate expectations and determine if it is time for them to be administratively discharged or transferred?
I think it's really important that we look at the fact that these behaviors have been happening for many years. They have been continually reinforced. So we can't expect someone to hear an intervention for the first time, make the changes, and just grow. That's not realistic. And we're teaching clients to be easy on themselves and not have this black or white thinking where either I do it right or it's completely wrong. So if you see a client engaging in old behaviors, not making the progress and not complying with treatment, do things, a lot of times people call it behavioral contracts. I reframed it as treatment re-engagement agreement, and going over that and all the expectations of treatment, what their treatment plan is, and what it means if they don't engage. And then you may reevaluate in a month and there may be progress because they may break it again, but you've seen growth. It's really reflecting on what's the objective of this. Are they making growth in their treatment plan? And if so, you keep working with them. But if you keep setting these boundaries and you don't see them taking any actions to change their behaviors and they continue, well, then it's probably time to either look at a higher level of care or maybe just another program. Because as professionals, the best thing we can do is acknowledge when we're not the best fit. And that shows like your skill set.
Which can be tough, but is necessary at times.
Right.
So when you're working with a client, how do you ensure that he or she understands the boundaries that are set for them?
I think the best thing to do is say it. And before you jump in and try to explain yourself, give them a moment to process it and observe the reaction. You can say, I feel like you're pulling away a little bit. You seem a little angry. Give them a second to voice that, because like that's the thing. We're not just there to tell them what to do. They get a say too.
Mm-hmm.
So give them a moment to process it, because it might take a minute. They may have to come back later. Observe the reactions, address the reactions, don't avoid it, and explain why. Again, it goes back to reflecting on what their original treatment goals were to begin with. And then, they may not accept it right away. You may have to keep readdressing it.
Sure.
And that's okay.
Sure. Okay. So when you're instituting a boundary with a loved one, does it risk a relapse for them?
I can understand this fear because, if a client is in the fight or flight mode, they're probably being aggressive and, threatening you with all your fears that you'll never hear from them again, that it's going to be their fault. But I think the important thing to keep in mind, if you don't set a boundary, that's actually risking the relapse, uncomfortable as it is.
Mm-hmm.
Again, it's you telling them, I love you so much. I'm not willing to engage in this and enable this behavior. But it's also important when you set boundaries in tough love, letting them know the door is open. When you're ready to talk about this, when you're ready to make the change, I am here and I love you. But until then, I can't participate. And yeah, they're going to curse, they're going to scream and make you feel horrible. And they may say it's a relapse, but that's the manipulation process happening right there.
Very good points. So how can therapists best avoid issues related to transference and countertransference when working with patients struggling with substance use disorder? If you want to answer that question generally, you certainly can, and then they provided an example if we want to go off of that.
So part of this, I think, being able to be aware of countertransference and transference is the rapport building. So you don't want to jump to conclusions right away. And I think it's important to reflect, so you can also bring it to your team, right? Get some feedback, consult with them. And if it continues, it's important to reflect on that. So like if you think they associate their parents with a therapist, or, like they're transferring it onto the therapist, well, okay, you take a minute and you, like I said, you reflect on what they previously shared. Like, I feel like you're starting to, be short with me, like you've said you are with your parents when you get upset. But it's hard because they need to trust you, because they aren't aware that, consciously aware that it's happening. So you don't want to push it too far, but I think it helps if you at least reflect on it yourself as a therapist and you talk about it with your team, so you don't personalize it, and you as a therapist can stay present and continue to help them push through that like interference in their treatment process.
Sure. And prevent some of the countertransference.
Exactly.
Okay, so who is the best person to hold patients accountable to behavior change commitments? Is it a family member? Is it the therapist, romantic partners, or ultimately the patient, him or herself?
It's everyone. Because at the end of the day, it's great if we have that external reinforcement of family, treatment, loved ones. And yes, it's great. It helps us on those days we feel horrible. But eventually, your therapist, who you may really like, is probably going to annoy you, and your family member is going to take you off. And that's not going to be enough. So you need to set like internal motivation going into treatment. Encourage yourself on those days. It's having that balance of feeling both internally motivated and externally motivated to hold these boundaries, because you have the same long-term goal: to be happy, to be present, to be sober.
Absolutely. So kind of along with that question then, um, how do you help these families set clear boundaries and to reinforce those boundaries for their loved one? Do you guys at Second Chance do family sessions when the client is in treatment with you?
Yes. So, when we have a client and they go through their biopsychosocial assessment, we kind of get an understanding of the family dynamics. And we might talk as a team like, does this feel like a family could be beneficial to long term treatment and like their recovery overall? Because sometimes they're going to come from very dysfunctional families where it's not healthy to incorporate that family member. There could be trauma associated with it. The family members could be using drugs themselves. So it's best not to incorporate it. But when the family member could be resourceful to the client, it's really important in doing so. So it's important also to remember that there's not clear-cut expectations for an individual and their families. So it's meeting them where they're at. What does this individual need? Not what we think someone struggling, generalizing it to someone
Mhm.
struggling with addiction. So ask the client themselves, what would you like to see? Ask the family. Have them both have an opportunity on their own without the other person, staring them down as they say what they want for the relationship, and then bring them together. And it's working collaboratively and saying, okay, like, the key is negotiation and looking at what you want for the relationship as a whole. And the end goal is that relationship. And we have to negotiate. It's not one way or the other.
Absolutely. Thank you. Um, it sounds like from the entire presentation that you've been giving, it's that, a trusting relationship between therapist and client is important, before setting these boundaries or challenging clients. So what are your recommendations for when that trust isn't there yet, or when a patient is really resistant? Maybe they're only in treatment because they've been court ordered or they're on probation. And so they're resistant to even building the trust that's needed to then set the boundaries. What are some suggestions that you have for helping to build that relationship, and how do you start setting those boundaries?
Sometimes when you can sense that resistance right away. Someone comes in, they might be very clear with you, like they don't want to be there.
Yeah.
And so that wall is up. So I would encourage you not to really get into therapy right away. And in some ways, this still is therapy. Ask them how their day was, engage them in their interests, and kind of building that comfort. And, if you have a similar sports team you like, engaging that way so they feel a little more comfortable to open up to you.
Mhm.
And start small, because if you jump right in and you try to go like, tell me about your trauma,
Yeah.
the paranoia, they're going to pull away right away. So it's like, start really slow. And what you'll see when you do that, they'll give you little tidbits. They'll stray away and tell you something pretty meaningful to help them in therapy. And you go with them. They take the lead. Okay, they're ready to talk about their mom. They're ready to talk about this ex, partner, and take their lead on those situations, and don't rush it. Because again, it's not us. Like, we're not trying to be the best therapist. We're trying to be the best therapist for that individual. So let the person take the lead.
That's great feedback. Um, Somebody has asked, why do I feel guilty setting boundaries, and how do I work past that or through that?
One, because we have grown up in a society that says that is backwards, that to love someone, you have to be overprotective and a helicopter. And we're worried that if we're the ones to set the boundaries, all the fears that we have are going to come true. And they may, but we have to remember at the end of the day, as a loved one, as a therapist, we don't have control over their lives. Just like you can't love someone sober, you can't force them to use, but you can promote different changes.
Hmm.
So, yes, it's going to feel uncomfortable because it's not natural and it feels backwards. And the loved one is probably going to make you, reinforce that thought process, and they're going to scream because they're fearful. So it's reminding yourself, okay, what is, taking a step back and being like, what is my goal here? Are my motives pure? Am I trying to help them? Am I trying to help myself? And if the answer at the end of both of those questions is yes, then you're fine. And just know that that uncomfortable feeling will pass.
Great. So boredom, a big threat to one's sobriety, is a challenging behavior that's, often present in early recovery. What are some strategies to help cope with with boredom?
That, I once heard someone say, and it was a previous client, it was so insightful, like the key to recovery is being okay bored. And because people are so used to like either being on a high high or a low low, like just feeling normal and okay is just not something that's very settling. So I think it's hard when you see clients, they're doing all the right things, they're going to work, they come to treatment, they go to their meetings, wash, rinse, repeat. And that's great. Like you want to encourage that because they're doing what they need to. But it's also being mindful of like, that's not going to really promote a fun life. And finding, it's not going to be exciting every week, but it's like, okay, can you take a couple hours on Friday and do something just for yourself? Maybe it's you switch up, if they're going to 12-step meetings, you switch up your meetings and kind of keep it a little new, get new perspectives, meet new people. Maybe you plan events that are just with family members or significant others that are fun, like trying new restaurants. And it sounds weird, but recovery is not just about going to treatment and going to a meeting. It's about being there for yourself, for your friends, for your family. So finding ways to live in those moments. So, giving them credit that they're doing what they need to do, but just cautioning them that like it's okay to have fun and to be happy in recovery as well.
Absolutely. Well, Caroline, I don't know if we have time for any more questions, so I'm going to wrap it up. But thank you so much for your time and your very informative presentation. And thank you so much to all of our attendees for joining us today. Or as a reminder, the presentation is eligible for 1 continuing education credit. So remember to watch your email from a link from cego.com so that you can complete your evaluation. And so before we close out today's webinar, I'd like to share some upcoming webinar opportunities that Karen will be hosting. Please save the date. Karen is going to be hosting our 6th annual Addiction Research Symposium, November 4th and 5th. Presenters are from NIH, the National Council for Mental Wellbeing, and Johns Hopkins. Our own Karen Medical Leadership will also be presenting. Registration is opening soon, so stay tuned for that. We will also be hosting a virtual open house for Karen Grandview Men's Programming on our Pennsylvania campus that will be hosted virtually on October 7th at 12 o'clock. And it will provide a really unique opportunity to meet our clinical team, to learn about our services, and take a virtual look inside our elegantly appointed facility of Grandview Men's. We hope to see you at one or both of those virtual events. So in the meantime, if you have any questions, please reach out to your local regional resource directors at any time for additional information, for resources in your area, or any questions regarding admission to any of Karen's programs. We will post a recording of the webinar on our website, and you will also receive an email from someone at Karen with a link to that website and the presentation as well, so that you can keep that for your reference. So thank you so much again to Caroline, to Second Chance for being part of this, and thank you to our partners, Encore Outpatient Services and Maryland Addiction Recovery Services. We are really happy for everyone's attendance today. I hope that you have a great rest of your day, and thanks again, Caroline.